Well, hello everyone, welcome. So we had just left off right here with this slide last time. I had to stop a little early. I had something I had to get to, but as we go through this, it's a good place to kind of recap, review, reminding ourselves what we saw last lecture. So I'm going to go back, and I've still got the diagram sitting here. So just as we remind ourselves, let's start at the body systems. And deoxygenated blood coming from the body systems will enter the superior and inferior vena cava. You would have seen this in the lab recording as well, coming into the right atrium. And from the right atrium, that blood needs to go to the right ventricle through the right atrioventricular valve or tricuspid valve. And in the right ventricle, we're going to go out the pulmonary semilunar valve, pulmonary trunk, pulmonary arteries, to the lungs, and the lungs capillaries will pick up oxygen. Oxygenated blood comes from the lungs to the left atrium via pulmonary veins, veins to the heart, arteries always away from heart. Then our left atria to left ventricle through the left atrioventricular valve. Then we go into the more muscular, thicker left ventricle. It must pump blood out to the body system, so it's got miles to pump through, and it's going to pump that through the aortic semilunar valve into the aorta, to it ultimately goes through all the arteries to go to your body systems. Okay, so this is a sequence that I will expect you to know. There will be multiple questions on this. I'd say minimum of 3 questions on blood flow through the heart. So usually that's kind of my minute thing that I usually do is if something's very important, you're going to see about 3 questions on that concept. Okay, so I'm going to set those aside, and I'm going to put some paper down here that I'll use to draw on in a minute. So as you can see, when blood flows, it's actually both are happening simultaneously, but what we were doing was tracing the path of blood for a single drop of blood. Then that was correct, but both atria contract at the same time, then both ventricles contract roughly at the same time, and blood is flowing through that. Okay. Now, to get blood to the heart, there was a mnemonic that I used to help us get all the vessels here, GAMPs right, and we're going to use that in a minute. So remember, we want to get the coronary circulation. We want to get blood to the from the heart itself to get that blood to the cardiac muscles, and then get that blood away from the cardiac muscle cells. So we have coronary arteries to take blood away from the heart to the heart itself, because remember, this is a subsection, we could say, a subcategory of the systemic circulation. And then we're going to see the coronary arteries. Remember, they are what brings blood to the heart, and the cardiac veins, what drains blood away from the heart. So this away from the heart's tissues, just like it was any other tissue in the body. So that can be a little confusing. We have to think about this as a subsection, that the heart is part of the body's systems, and veins carrying blood away from it, and arteries carrying blood to it like it would any other organ. Now the coronary arteries, there are 2 of them. There's a left one and a right one, right and left. They come off the base of the aorta. So when the aorta comes up, they're going to come right off of it. And what happens is when the ventricle squeezes and blood goes up into the aorta and the ventricle relaxes, that pressure in the aorta drops and the blood comes down, and recoil the aorta helps to push some blood down into the coronary arteries, giving that blood supply there. So when that happens, that blood that enters that will go into the right or left coronary artery. Now the right coronary artery, what we see is it supplies blood to a huge amount of the body. It supplies blood to right atrium, both ventricles, left and right ventricle, the SA node and the AV node, both. So it's going to be the one, if you destroy this, if it's gone, you're dead. There is no surviving that. If you block it too much, that's it. Now, one way to remember the branches, right coronary artery, RMP, RMP, right coronary artery, marginal arteries, and posterior interventricular. Sometimes we call this the posterior descending artery as well. Commonly might be referred to that in clinical practice. Remember, this is on the back side. We saw that. We'll talk about who it pairs with in a minute. Now, the left coronary artery, you will see it will lack. LAC, lack. Left coronary artery has the anterior interventricular artery, and the circumflex comes off of it. Now, the left coronary artery, what you guys are going to notice about left coronary artery is it's taking blood to your left atrium and your left ventricle and the interventricular septum. So you got 3 areas there. So it is important as well. Now, the so-called widowmaker is your anterior interventricular artery, sometimes called the left anterior descending, or the LAD. Now, widowmaker, there's 2 problems I have with that. Number 1, it's not more likely to cause death of a patient than any other. And also, it makes you widows, of course, would be the female left behind, the wife left behind from the death of her husband. But women die of heart disease. It's one of the leading causes of death, if not the leading cause of death amongst women. So we've got RMP, right coronary artery, has the marginal and posterior interventriculars. And LAC, left coronary artery, has the anterior interventricular and the circumflex. Okay. Now, with that, we have blood from the heart muscles, and they're going to end up going to the right atrium via the foramen of the coronary sinus. So it's going to get blood from the heart muscle. It's going to enter the foramen of coronary sinus in the right atrium. And remember, we have 4 major vessels. We have your great cardiac vein, the posterior cardiac vein, the middle cardiac vein, and the small cardiac vein. Now, GPMS is all the branches of the coronary. So CGPMS. Not a great mnemonic that I have there for that one yet, but GAMP's right is going to help us understand what it drains the same area as the arteries that provide it. So GAMP's right, GA stands GAMPs of GAMPs. The GA in GAMPs stands for great cardiac vein and the anterior interventricular. We're going to see the great cardiac vein drains blood from the same area that the anterior interventricular artery provides. Then we're going to see our MP, our middle cardiac vein, drains blood from the same area as provided by the posterior interventricular artery. S right, small cardiac vein, drains blood from the area that the right coronary artery is also kind of running along with it. So not all the same area that it does provide or drain, rather, but it runs along with it anatomically. And then, so GA, MP, S right. So GAMP's right is a way to remember. Get your GAMP's right. I just added get your with that to make the mnemonic work a little bit better. GAMP's right. GAMP's right will help you keep up with these for lab and lecture. So usually I find that the coronary arteries are easier to learn than the veins. So you could see all those here. We discussed them and showed them in diagrams and models in the lab as well. So now a big thing that we're going to talk about today is how we make muscles contract. Now the thing that we need to make sure we understand about heart muscles is if we step back in A&P1 histology section, you guys would have seen that heart muscles are referred to as involuntary striated, which means they do not need neural impulses to make them work. They are controlled automatically. Cardiac muscle tissue contracts automatically. We say it has automaticity to it. It's automatic. Okay, automaticity. Now there are 2 types of cells. We're going to see 2 types. One of those is the conducting system cells. Now they're very skinny, very specialized cells. So you will see these guys in green in this picture that I shared, where it is incredibly much smaller. They are not there to contract. All they do is they are there to conduct electrical impulses, action potentials, to the contracting cells. And the contracting cells are the more red ones that you're going to see on this diagram here, this picture that I borrowed from online, Visuals Unlimited. And these cells here, that's the conducting. These are some neural tissues because you will find some neural stimulation to the conducting systems. We're going to talk about that. But your contractile cells, they are the ones that contract to move blood. They act much like skeletal muscles. So they do have the same contraction cycles as skeletal muscles. If you guys weren't very good with that, if you look at my notes from A&P1, you'll see that. But as we talk about this, what we want to do is to help us understand the conducting system. Now, to grasp the conducting system, I like to sketch it out. This is an important thing to know. You're almost guaranteed to see this on entrance exams. So it's a big thing. You will discuss this throughout programs. So if we were to take our right atrium, right ventricle, left atrium, left ventricle here, what you're going to see is in the upper part of your right atrium, you're going to have what is called a sinoatrial node, SA node. The SA node or sinoatrial node is going to receive information, so the central nervous system will come in using the ANS. Remember, this has sympathetic and parasympathetic. Symp and para will both come into this and be able to upregulate and downregulate. Remember, this is a location of the beta-1 receptors. Then around here in this area, you're going to find an AV node. So there are these two nodes, SA node and AV node. Now, SA node and AV node need to be able to communicate with each other. Now, the SA node will send signals across the atria through something called the Internodal Pathways. Now, what is that? If you think about internodal pathways, it's between two nodes. These are those conducting system cells, and they roughly fill a pattern somewhat like this throughout the heart tissues. Now, from that, we're going to take this AV node and we're going to fire it. Now, with this AV node firing, we're able to take this AV node, and let's use orange here. And we're going to have a thing that comes off. It's not actually as long as what I've made it look like, but called the bundle of his, or the AV Atrioventricular Bundle. Now, with those bundles, there are two branches off the bundles. There will be one that goes towards the right and one that goes towards the left. So I drew one left, one right. So there is the one on the right called the right bundle branch. Now, this will be important. You may have a right bundle branch block or a left bundle branch block when you deal with patients, cardiac patients. Left bundle branch. Okay, so there's a left and right bundle branch. And then off those bundle branches, I'm going to use this bright lime green color coming off of both of these. And these radiate out into the ventricles. These will represent our Purkinje Fibers. Purkinje Fibers. Okay, that's our Purkinje Fibers. Now, a good way to remember this in order is if you have all your patient, if you have a patient, they just found out their loved one's in the hospital and they're all having a heart attack. Now you have to save his kin. Now, this isn't all of it, but this gets most of it. Save his kin. Let's put that there so we have save his kin. SAAV his and Purkinje fiber. Okay? This at least gets you most of it in the way. This isn't everything, okay, but it is at least a good way to get it generally in order, so you know the order of sequence for the signals to go through. We are going to start with the SA node, go through the internodal pathways to the AV node, down to the bundle of His, to each of the bundle branches, right and left bundle branch, to the Purkinje Fibers. Now this gets most of it, but not all of it for save his kin. Okay, but it is helpful nonetheless to have something like that. Okay, so let's take a look at that. So what we have is, and we've mapped this, our sinoatrial node, SA node. That's up superior right atrium. Then roughly between the areas located between left and right ventricles here, and I've kind of drawn it where it is there for clarity, but I could have kind of moved it a little bit. But he gives off there's also other conducting cells. There's the internodal pathways and the AV bundle or bundle of His. Then there are the bundle branches, left-right bundle branches that come off that, then the Purkinje Fibers. So what happens is save his kin. If everybody's having heart attacks, now you got to save his kin. And that's an easier way to remember. Now I kind of changed it a little bit on the camera drawing than I did here. SA node, AV node, bundle of His, Purkinje Fibers, but remember, overall I've got it written up here. This is a little simpler conduction pathway. It's easier to remember. Now the SA node that we drew on the paper, this guy here, he's kind of on the back of the right atrium. He's near the vena cava. We call this the pacemaker node. Since it's the pacemaker node, this pacemaker starts the contractions of the heart, and it also stimulates the AV node. It sets the node here. Now, there are two things. Now, we said it gets ANS innervation. Okay, we said it gets sympathetic and parasympathetic. With the para here, para equals, para is going to be vagus, which is cranial nerve 10. That's what's going to be coming in. It's going to be the vagus nerve that's going to come in, parasympathetic innervation, and sympathetic innervation, remember, together are going to set this. That's all part of your ANS coming in. So it's two parts with the vagus, cranial nerve number 10, and then the sympathetic is going to use two methods actually. It's going to be using hormones found in the bloodstream, and it's going to be using from the suprarenal medulla, and then it's going to be using direct sympathetic cardiac. Remember we talked about the cardiac plexus, things like that, with the heart itself in the autonomic nervous system. We talked about that stimulated. So fibers of the cardiac plexus and the vagus nerve. Now vagus decreases it. Vagus is going to be using muscarinic receptors, because the parasympathetic nervous system releases ACH to a muscarinic on the effector, and that's going to lower the SA node firing, decreasing the heart rate. Now sympathetic is going to come in, and it's going to increase the SA node firing, and that's going to result into the increase in heart rate, because the norepinephrine is going to bind to the beta 1s, and that's going to be found in the SA node. That's going to fire it, and that what happens is, remember the word depolarization means we get positive. When you depolarize the SA node, the internodal pathways take it to the AV node, or we can go gap junction by gap junction through those cells from each cardiac muscle cell till it gets there. So there's a wave of depolarizations going from the SA node to the AV node to make that AV node fire. Now the AV node has got a break on it. The AV node is the node that says you need to stop and smell the roses. Now it's right there kind of between the right ventricle, left ventricle. I've kind of put him off to the side for clarity, but it delays it. It says about 100 milliseconds, and it delays that, and it wants to let blood leave the atria and let blood fill the ventricles. So it allows a delay. That delay should be there. It's normal. Now the AV node, only way it connects to the ventricles is the bundle of His. So it has to go through the bundle of his to the left-right bundle branches to the Purkinje Fibers. Purkinje Fibers, easy to remember to spell. Per, like cat purr, P-U-R, Kinji, Purkinje Fibers, okay, to the heart muscle cells. The ventricles should contract roughly at the same time. Now, I'm going to tell you guys, for this system here, you will need to know the pathway and what it goes throughout here. I will not test you on the times. I will have it, but it is important to know this and understand it and have this as a backdrop for when you learn to read EKGs. But right now, we're not going to memorize the time. When you guys are looking for aberrations in EKGs, they're not going to look like this. But it is important to understand normal EKG tracing. I'm not going to make you memorize how long. Now, we're going to start out time 0. So if I have a stopwatch, and as soon as the SA node is activated, I click the stopwatch. Stopwatch is going now. So time 0, bam, I hit it. And from the SA node to the atria, it takes about 50 milliseconds for it to get there through either the internodal pathways or gap junction to gap junction through each myocardiocyte till it gets there. Now that's important to understand. As you guys see, this is what makes that P wave of an EKG. When that P wave of an EKG is upside down, somebody has what is called an ectopic foci in their heart, then they may need to go in for cardiac ablation to burn that out. What this is there's areas of tissue that are in the heart they may have been born with that are firing too soon, and it's actually getting to the SA node before it should, and it's messing up the cycle. Okay, you'll get a premature atrial contraction from that. Okay, so this is why an inverted P wave can mean they're having premature atrial contractions due to ectopic foci. So what's going to happen is once it gets to the AV node, it's delayed about 100 milliseconds. So there's like a 100 millisecond delay there. It holds on to it, won't let it go, and then after that, it lets it go. That's going to allow the atria to contract. That's now been 150 milliseconds. Now that it goes down the bundle of his to the left-right bundle branch, Purkinje Fibers, about 175 milliseconds it takes to do that. Then it goes to the myocardium, causing the ventricles to contract, which took about 225 milliseconds for this to happen. Now, again, do not concern yourself with the times. Make sure you do know the steps. I will ask you guys where it goes next, things like that. This is something you absolutely have to understand to be able to do an EKG tracing. When you guys are in healthcare programs, you're going to see this. And if you don't have this foundation, this makes no sense to you. Okay? It just makes no sense. So this firing to time heartbeat, and that's what the cardiac conduction system does. It is there to make sure it is like having your spark plugs on the right time in your car so it don't backfire. Okay? If it backfires, you may not contract properly, and that could have implications on the body. You wouldn't be able to get enough blood to the lungs to get enough oxygen to make energy to take ATP. So what you're going to have is this overall kind of firing here where this pathway, remember, you get the SA node, sends it to the AV node delays it, sends it to the bundle branches, through the bundle of his, bundle branches, Purkinje Fibers. Okay, sorry. I felt my phone going off. I need to check it. Alright, now, this is going to be a big topic we're going to hit. You must understand this for pharmacology. I'm actually not going to use the back side of that paper since there was stuff written on it. So what we're going to do is set this up, and I want to set up a drawing. Now, real quick, when we go back, you got to notice we're going to do 4 steps. Since we're going to do 4 steps, what I'm going to do here is I'm going to take my red pen, and I'm going to draw 4 cells, and they're going to look like this. So I'm just drawing 4 rectangles where it's open on one end, like this, and we're going to draw 4 of these together. And but if you guys understand this, pharmacology is going to make a lot more sense, a lot of cardiac pharm, things like that. And there's going to be a lot of drugs. Now this will be our time and it's measured in milliseconds. And then this up here will be our voltage, measured in millivolts. Okay. There will be some values we're going to memorize. So what we want to do is walk through a little how this works. And let's go to our notes here. And I'm going to go back and forth with this. We're going to start with resting. Now, a normal myocardiocyte rests about -90 millivolts. Now, that's a little different from a neuron. Neuron's about -70. Most cells, other than the neurons, might be around -90, -95 millivolts, somewhere around its resting potential. Now, its resting potential is when it doesn't do anything. But number one is going to be resting potential, -90 millivolts. Okay? So over here, let's write out right here, -90. And on next to this, we want to write number 1. And what we have to do is, this is caused by a good friend of ours. This should be a dear old friend that we know from A&P1 very well. This is the sodium, potassium, ATPase pump. I guarantee you're going to see the sodium, potassium, ATPase pump on this exam. Okay? Something about it. So you need to pay attention to this. You have to understand this. A lot of drugs are going to deactivate sodium, potassium, ATPase pumps. Cardiac glycosides, for example, digoxin, digitalis, that kind of stuff. So it's important to understand how it works. So what we're going to see is this guy brings in 2 potassium cations into the fluids inside, and that is called the ICF, if you don't remember that from A&P1, and the ECF is the fluid outside. 2 potassium cations in, 3 sodium cations out for every ATP that I give it. So if I give it an ATP, so hence sodium, potassium, ATPase pump. 2 potassiums in, 3 sodiums out. Sodium, potassium, pump style. Pump, 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 pump. It's going to remember Gangnam style to remember the sodium, potassium, ATPase pump. What you going to do with all that sodium inside your cell? I'm going to get it pumped. Get it pumping my pumps. So my sodium, potassium, ATPase pumps pump out 3 sodium cations and bring 2 potassium cations into the ICF. Now, because there are in the ICF, you will have a very high potassium environment, but a very low sodium environment. And in the ECF, you will have a very high sodium environment and a very low potassium environment. And this creates the ICF having a unique charge where it's roughly negative, as we said, -90 millivolts. Okay? So what we say is it has negative. ECF will actually be quite positive, and we say this cell has been polarized because it's negative in, positive out. Negative in, positive out. Okay? Okay, sorry, I got to pause and get a phone call. Sorry about that. Okay, so that is our stage number 1. So that -90 millivolts there, stage number 1 is going to be set. And let's write stage 1, -90, resting potential. And right here, I'm going to write under that it's resting. Okay? So this will be a very useful drawing for you if you guys do this with me. We want to make sure you can do this. Okay, so that gets our resting potential. The heart is not beating during this time. Now, what happens next is there's going to be a depolarization. Remember, depolarization is when heart or any other excitable cell gets stimulated, becoming more positive. It's going to become more positive. Now, when it comes more positive, there is a depolarization, and we're going to talk about that. It's going to go up to about positive 30 in a minute. So what's going to happen is, and I want to talk about this, I don't like the way that necessarily I did that, but I need to tweak my notes a smidgen, so let's put negative 75. Now negative 75, put a dotted line, and we're going to say this is threshold. Now, threshold is the minimum charge you need to reach to cause an action potential to form. So this value of negative 75 millivolts is going to be very important. So how are we going to do that? Well, we're going to get to stage 2, and let's make this one stage 2, and let's set the stage. Remember, it was negative 90. It was polarized. We had a very high potassium, and very low sodium environment. Okay, and we're going to need that. And then outside is very high sodium and very low potassium. Now right here we're going to have a gap junction. And remember, that is a type of intercellular junction that allows ions and other things to pass through. So what's going to happen here is this gap junction, you're going to start to have sodium ions here diffusing in. Why? Well, one reason is it's going to be attracted to the low sodium, high to low, simple diffusion through the protein, facilitated diffusion. It's attracted to this. The other thing is sodium is a cation, and it's attracted to the negative charge there. Opposites attract, okay? So it is a twofold chemical and electrical gradient that brings the sodium in. And the sodium value starts to slowly increase. As it comes in and slowly increases, that sodium level will hit negative 75, okay? And shift it to a negative 75. And that's what's important, is negative 75 is a threshold level. Now, what does that mean? Well, when negative 75 is reached, the voltage-gated sodium channels will open because they have reached threshold, and a ton of sodium will rush in. And it's going to make this cell shoot up to all the way to about positive 30. Okay? And this is number 2 here. Okay? This rapid depolarization. So we're going to write under this depolarized. Becomes depolarized. Okay? This is the depolarization state. Now, as that goes up, these are called fast sodium channels. So they are very fast. They open up very quick. They're fast. They open up and they're going to close. So this is a very steep rise. Now, as it gets towards this positive 30, there is something very interesting going to happen at stage 3, the most unique. Now, pretty much this is the same as any muscle cell. But stage 3 right here, this is what's going to be very important for us to really grasp what makes this unique. Now, what's going to happen is, here our old friend is going to kick in, and we're going to actively transport the 3 sodiums out and 2 potassiums in. And as that sodium levels, we're going to start to drop the sodium down. Now remember, when that happened, let me write here, it got more positive up to plus 30 here. And we said it was depolarized because the ISF got positive. Now we're starting to lose sodium. So what's going to happen is that drops down here in stage 3. We don't want that to happen. So what we're going to do along with this is we're going to start to bring in calcium cations. Okay? As we approach that positive 30 millivolts, those sodium channels close, and we actively pump out the sodium, and we're going to keep it fairly close, hovering somewhere around 0 millivolts for a while here, and that is stage 3. Okay? Sorry, I drew that without the camera. And that is plateau phase. Plateau. All right. Now, eventually, what's going to happen is, in stage 4, everything's ready to go. We're going to open up potassium channels, and potassium is going to leave. The cell is going to drop back down. It's going to drop. Then our old friend's going to reset it for another round. Okay? And it's going to become repolarized because it's going back to a more negative. Okay? Now there is a brief undershoot here, a hyperpolarization that also typically happens during most electrical activities. But it's polarized, and our old friend, the sodium potassium ATPase, resets it. So, I'm going to say that if you can draw this out and understand it, you're going to need this to understand pharmacology. Keep your drawings, keep your notes. This is almost a necessity to master that, okay? To really understand cardiac drugs, what they're doing, what you need to look for, and things like that. Okay. So with that, let's, down here you can actually see the differences here as well. So this is a very unique graph. Mine's a little different, a little steeper in places, really trying to accentuate the differences. But now, remember refractory periods. There are periods of time for cells when they can or cannot be stimulated. Now, the absolute refractory period for cardiac muscles and any other excitable cells, there is the absolute and the relative. The absolute is the period of time where a cell absolutely cannot respond to a second stimulus. It doesn't matter how much we try to stimulate it, it absolutely cannot. And it's about 200 milliseconds. Then there is a short time after that where it can respond, given that you give it a relatively greater stimulus. That's the caveat, the catch. Cell can respond, but it has to be a relatively greater stimulus. That's the relative refractory period. Now, there's differences in these two with skeletal muscle and cardiac. Skeletal muscles have a very long relative refractory period. So there's a longer period of time I can stimulate them if I give it a relatively greater stimulus. And that's important if I want to be able to keep a sustained contraction. Heart does not want to do that. Heart does not want to maintain repeated constant stimulations because then they'll fibrillate. You don't want that, they won't work. You need to make sure they have a short relative and a long absolute. That way they beat like they should, not muscle contractions trying to keep constant tension on a tendon. So that's why skeletal muscles have long relative and short absolutes. So it's backwards. Cardiac muscles need short relative and long absolutes so that they can maintain, so they don't go into a flutter and things like that. But when electrical problems do happen, they can. That can happen with acid-base disorders, with electrolyte issues, other electrical things. So that's when we get into things like cardiac arrest, which is an electrical problem, versus a heart attack, which is a vascular muscle problem. All right, now to also get this, I need to help you guys understand the cardiac cycle. The cardiac cycle is basically, I've got a heartbeat and then another heartbeat, okay? It is, I got a start of one heartbeat to the beginning of another heartbeat. So what is it? It's a lub-dub. It's a lub-dub. That's what it is, okay? And there are two major phases. There's systole, where a chamber squeezes, and there's diastole, where a chamber relaxes. Systole squeezes, diastole you can relax when you die. Diastole, so what happens, diastole relaxes, systole squeezes, systole and diastole. Now, when the heart chambers, when they do that, when they contract, pressure inside that chamber increases. When they relax, pressure inside that chamber decreases. Now, blood is a little bit like a college student on the first day of class. Let's say you guys walk into class and it's probs and stats, and your professor says, look to your left, look to your right. None of those people will be here after the first exam. I'm the roundup. And I'm going to wipe you guys out, okay? That actually used to be Dr. Cleveland, who taught chemistry here. That's what he always said to the students on the first day. So what you would see is that you would say, forget this professor. They're insane. I'm leaving and I'm going to take a better professor. So you're going to try to leave an area of high pressure to an area of lower pressure. That's what blood does. Blood leaves a chamber when systole occurs, and blood fills a chamber when diastole occurs. Okay? Blood leaves a chamber when we squeeze it. Blood fills a chamber when we relax it. Okay, if we got that, that's going to get us. Now, to understand this a little bit, we want to have, there's a thing I want to do here, and I'm going to see how on earth and how well this looks when I do it, and see if I can do this. I may have to go past my desk. If you can't hear me well, let me know. But I always kind of do this little dance for this, and it looks like you might be able to see me okay here. So, but I hope you can hear me. I see it pegging. So what we're going to look at is the cardiac cycle, and you should be able to see both, as it looks like the confidence screen is getting both here. So there are two things being recorded. So I am going to make sure that, well, tell you what I'm going to do, just so I can see I'm going to make sure that I'm actually going to be visible, is I'm going to set it off to the side so you can see it, just so I know I'm in screen, because it's hard to tell where I am. So the cardiac cycle, remember, blood fills a chamber when a chamber relaxes, and blood leaves a chamber when the chamber contracts. There are two stages: systole is squeezing, diastole is relaxing. So if my arms are going to reference my atria, and my legs here are going to reference my ventricles. And we're going to start out, this being your diastole, when my arms are apart, and when my legs aren't bent, that's going to be ventricular diastole, atrial diastole, ventricular diastole, atrial systole, ventricular systole. Okay? So we're going to start here with all my chambers relaxed, all valves are closed in the heart, and we're going to see that my ventricles are going to be mostly filled with blood. They're almost entirely full of blood, and there's a little bit of blood left. So to get the last drops of blood out of my atria is going to squeeze. And when the atria squeezes, that blood goes through the AV valves to fill up the ventricles. So now my ventricles are maximally filled with blood. Okay, we have now had atrial systole. Ventricular diastole, the ventricle filled with blood. So now as my atria start to relax, the AV valves will close, then my ventricles can contract. Remember, my AV node is saying, I need time for the atria to squeeze, fill the blood up with fill the ventricles up with blood. Atria start to relax, and the ventricles start to squeeze. They're squeezing, but blood isn't moving. This is our isovolumetric contraction. Why? Though my ventricle is contracting here, it is not moving blood. So it squeezes until it can produce enough force and pressure. Cardiac ejection, blood goes out to the aorta during a ventricular systole. So isovolumetric contraction, enough force is produced. Ventricular, so we have a cardiac ejection happening. So now with the cardiac ejection, blood has went out to our body, and my ventricles relax, and my atria are now free to receive blood. So blood starts to get to my heart, and it starts to fill up the atria. Atria start to fill up, and they start to get a lot of blood in them, enough blood that during atrial diastole, it opens, enough force opens the AV valves, and we get the passive filling of the ventricle to where it's almost entirely full. And once it gets almost entirely full, the atria squeezes, puts that blood down in there. Atrial systole, atrial diastole. Ventricular systole has two parts. It has a isovolumetric contraction and then cardiac ejection. And then, so if we have atrial systole, atrial diastole, isovolumetric contraction, cardiac ejection, ventricular diastole, atria receive the blood, passive filling of the ventricles. Okay? So you will see that during that, and it helps you guys. So when the ventricles contract, you have blood leaves those ventricles through the semilunar valves. Okay? So during atrial systole, AV valves are open, but the semilunars are closed. Atria forces blood into the ventricles. We have a mostly filled ventricle. Now the ventricles are filled. Atrial systole ends. Atrial diastole begins. All valves close. Ventricular systole will start to push the AV valves fully closed and does not open the aortic semilunar or pulmonary semilunar yet. So if it's not able to produce enough force to open that valve up, we call that isovolumetric contraction because the ventricle is contracting, but the volume of blood in that ventricle stays the same. Now, ventricular systole then also comes up with your cardiac ejection, where the pressure that the ventricle squeezes and produces is enough to actually exceed what is pushing down on your semilunars, so blood is ejected. The AV valves are closed, but the semilunar valves open. Ventricular diastole, the ventricles are relaxing. Blood is coming back into your atria. The valves are closed, but then what happens is they passively fill with blood because when the atria gets enough blood in it, it will basically just open the AV valves and the blood dumps into the ventricle and fills. Then the atria contracts to force the rest of the blood down into the ventricles. Okay? And I will ask you guys a question about the cardiac cycle, where I'm going to ask you something like what happens during this, like during which phase does a cardiac ejection happen? Something like that, or near which of these would all the valves be open? They're not. There's never a time when all valves are open. There is a time when all valves are closed. Ventricular systole is when a cardiac ejection happens. So there's two parts of ventricular systole. There is an atrial systole. There's an atrial diastole. Basically, you will see that atrial systole begins and atrial diastole, basically, though is not on this list, it is happening because the atria are allowing blood to come in. The way we try to see that is if we start with a mostly filled ventricle, the rest of the blood that's in the atria squeezes, fills that blood up into the ventricles. Then the ventricle starts to squeeze, but it can't make enough pressure to open the semilunars. Then it does, and a cardiac ejection happens. Then we're going to see that ventricular diastole, as it's relaxed, blood fills the atria passively. Then that blood weighs enough to open up the AV valves and fills the ventricles passively. That's what we mean by that. The ventricles fill, then the atria squeeze to fill the rest of the blood up, and we go round and round. We always start here with atrial systole, okay? Now, this is trying to show you guys all those changes where we started with a mostly filled ventricle, then I got to go to another one here. Sorry. This is the volume of the ventricles. If we started with a mostly filled ventricle, then the atria squeeze to fill up the ventricles. Then the ventricles start to squeeze for a while. They're starting to squeeze. You could see it starting to squeeze, and for a while it's not moving blood till it produces enough pressure to open the valve, and then the blood leaves. Then we start to refill the ventricles passively. Then atrial systole fills up the ventricle the rest of the way. And that's what this is. Blah, blah. Okay? Now, there's some terms we need to also know. There's a normal heart rate that's somewhere between 70 to 100 beats per minute. If it's abnormally slow, we call this bradycardia. Think about there is no such thing as a heart-pounding episode of the Brady Bunch. Bradycardia, very low heart rate, slow, bradycardia. Tachycardia, someone is dressed tacky for your party. Maybe they're wearing a halter top and fishnet stockings. That would be very tacky to wear to your fancy party. It's too fast, abnormally fast heart rate. Tachycardia is a fast heart rate. Pulse is what we're measuring, usually either here in the neck or at the wrist. We go for a radial pulse or a carotid pulse. We can measure heart rate, and which measures heart's electrical activity, which is tied to the heart rate. Is called an ECG or EKG. EKG comes from the German K for cardio. ECG just comes from the English, the normal version, right? And auscultation is listening to your heart with the stethoscope, listening to the valves, listening for murmurs, things like that. Now, another thing we're going to draw here, which is tied to the electrical activity here, okay? This is a very important thing to know. This ultimately is what creates this that I'm going to measure. Now, what we're going to do is I'm going to get multiple colors here. I think, let's see, P wave, Q, R, S, and T. Okay, there we go. Okay, so there will be a baseline that we always have, and it's going to all just be that baseline there. And then what we're going to do is start with our P wave. P wave. The P wave should look something like this. This is our P wave. Then we're going to go into a Qrs complex. Now, the P wave, what you're going to see here is your Q, R, and S complex, which does include all of these. You're going to have a Q, R, S. Sorry, I should have drawn over that. Oops. And what I should have done here is use green here. I apologize. I wasn't used to using multiple colors to do that. Let's just do this. I thought I would try to be cute here. I was trying something new, and I'm like, I didn't like doing that. It's what you get for coming in first thing in the morning. And I've got class soon. Here we go. There we go. Sorry about that. Okay, so there is a P, a Q, an R, and an S, and a T wave. Now, we call this area right here the QRS complex. So we have P, QRS, T. A, B, C, D, E, F, G, H, J, K, L, M, N, O, P, Q, R, S, T. Okay, so P wave. What happens in the P wave? That is when the atria depolarize. And that means they're about to contract. Atria depolarize during P wave. During the QRS, what you're going to see is the ventricles depolarize here. And I'm going to write a secret note down here to all my students. This is my secret note. Atria repolarize. Okay? That's my secret note. You're not going to get tested on it here, but I could tell you that is a great question for them to put in your nursing exams when you do EKGs. They love to ask that. They said, during which of these events does the atria repolarize? They repolarize during Qrs complex. It's just you won't see it because it's masked by the electrical activity of the massive ventricle. And the T wave here, that is when the ventricles repolarize. Okay? And I'm going to ask you what happens during these events on the test for sure. I was trying to be cute with the different waves, but this is just simpler. And I would always ask you guys to draw these out and write down under them what they do. It will help you get this down a lot better. Okay? Now, of course, when the ventricles repolarize, they're going to relax. When the ventricles depolarize, they're going to contract. And when the atria depolarize, they're going to contract. When the ventricles are going to repolarize, they're going to relax. Much like skeletal muscle tissue. Okay? So as you can see, the normal EKG tracing can be produced from the activities that's going on throughout your heart's electrical system. Okay? Now, auscultation of the heart, you will hear the love dubs. The love dubs of the heart are heard. Normal heart sounds are heard using a stethoscope. There are 4 of them that we will listen for. And I've got to fix this slide here. There's some couple little, one little issue I'm having with my formatting that I just saw that's bugging me. Now, the love dub is S1, S2, the ones you're going to hear. S1 is the love, S2 is the dub. S1 is produced in the AV valves. S2 is produced in semilunars. AV valves open first in the cardiac cycle. Semilunars open second in the cardiac cycle. S3 is blood going into the ventricles. Now, you're normally not going to hear this unless there is a ventricle defect or a defect with a valve or something like that, and when blood flows into it, it makes a sound. S4 is atrial contraction. Normally not going to be heard, but if you have an atrial defect, atrial septal defect, like a foramen ovale that didn't close, a patent foramen ovale, a PFO, then you would hear that. You would hear some weird sounds. Now, well, I'm going to pause for a second. I'm going to bring up a video. And actually, before I show you the video, I wanted to show you, if you have not checked out my channel, please do. I do have a cardiovascular playlist. And on the cardiovascular playlist, I actually have a video of me drawing out the coronary action potentials, things like that. So please do take advantage of that if you guys haven't. But what I wanted to show is, and what we're going to do is I was going to play that. I think this is the one that I want. Is the one that plays some variations of it. I think this is the one that I liked.
With healthy heartbeats, it makes a lub-dub sound. The first heart sound, lub, also known as S1, is caused by the closing of the AV valves after the atria have pumped blood into the ventricles. The second heart sound, dub, or S2, originates from the closing of the aortic and pulmonary valves right after the ventricles have ejected the blood. The time interval between S1 and S2 is when the ventricles contract, called systole. The interval between S2 and the next S1 is when the ventricles relax and are filled with blood, called diastole. Diastole is longer than systole, hence the lub-dub, lub-dub, lub-dub. Heart sounds are auscultated at 4 different sites on the chest wall, which correspond to the location
I wanted you to be able to hear it. Let me see if I can get the sound. Okay.
Pulmonic, tricuspid, and murmurs or whooshing sounds produced by turbulent flow of blood. Murmurs are diagnosed.
So you can actually hear it there, so I want to make sure you guys...
cycle. Their changes in intensity over time, and the auscultation site where they are best heard. Examples of conditions associated with common...
Alright, so I just wanted to make you kind of familiar with that, okay? So just so you can kind of see what's going on, and that also gives you something big. Now, we're getting ready to go into some very important sections here, the cardiodynamics. This is something you're going to have to understand and really know for the long haul. You're going to have this throughout a lot of your programs. So I'm going to make sure you guys can help you understand it. So what we want to do is I'm going to do kind of what I like to do first is just start off by sketching and drawing. Now, I want to start off by reminding ourselves of your basic, what we refer to, guys, as cardiac cycle. Remember that during an atrial systole, atrial diastole, ventricular systole, ventricular diastole. During systole, blood leaves our chamber. During diastole, blood fills the chamber. Now, if I talk mostly about the left ventricle here, and I'm going to just label left ventricle there, that there is a time when the atrial systole squeezes blood into your ventricle, okay? And when we saw that, that gave us an amount of blood. So I got to pause real quick. Sorry about that. I had to take that phone call. Okay, so now I got there where I had left off. So during atrial systole, blood will squeeze down. And remember, we started with the mostly filled ventricle. Then atrial systole fills that blood up. Now, since we are coming to what we call ventricular diastole and the end of ventricular diastole, we call this the end diastolic volume, abbreviated EDV. Now, during a ventricular systole, this blood will leave and go out the heart, and that will have a volume of blood that will be left at the end of ventricular systole, called the end systolic volume. And this amount of blood between here is what actually got pumped out, called the stroke volume. So stroke volume equals EDV, end diastolic volume, minus end systolic volume. You will need to memorize that equation there, okay? That is an equation you're going to have to memorize. So our two things here is an end systolic volume and an end diastolic volume. End diastolic volume, volume of each ventricle at the end of ventricular diastole. That's what's going to be there when ventricular systole happens. After ventricular systole, there's an amount of blood left over. That's what's going to be available at the start of ventricular diastole to fill up with blood when passive filling happens. And that remaining blood is the end systolic volume. And the stroke volume is the difference between that. And the percentage of the EDV represented by the stroke volume. So the percentage of EDV, we're going to talk about that in a minute. Right here, we're going to talk about that in a minute and calculate that. That is something you're going to see. And the cardiac output is the amount of blood pumped by your left ventricle in 1 minute. Something else we're going to see. So let's get into some of this cardiac math and make sure we can do this. Now, the first thing is going to be cardiac output. Cardiac output, we want to make sure we can calculate your cardiac output. Cardiac output, CO, is your stroke volume times your heart rate, or heart rate times stroke volume, because with multiplication and addition, the order of these do not matter. Okay, so stroke volume times heart rate. So now we know how to find stroke volume. We have that. Heart rate is measured through a pulse. So we're going to practice these in a minute, but these are two equations that we need to know right now. There'll be a third in a minute. So what we're going to see with those two equations, let's use those. So what I want to make sure that we understand, and I'm going to use this a little bit, is to what happens with your EDV and your ESV. Okay? And if you change them. So let's start off with our heart here. And let's say, for example, that now my EDV was down here, which means this is a decreased EDV. When the heart contracts and produces a stroke volume and it goes down, we will notice that you decrease the stroke volume. And if our EDV were to go up, so increase in EDV, if EDV were to go up, and this contracted down, stroke volume would go up. Okay? So, you will notice that EDV, an increased EDV, equals an increased stroke volume, and a decreased EDV equals an decreased stroke volume. Now, the vice versa will be true. If I increase the ESV, there's more blood left over. When the heart pumped, this would mean that less blood went out. So stroke volume and EDV goes up, stroke volume goes down. And if ESV went down, stroke volume went up. So that means if there's less blood left over, more blood went out. If there is more blood left over, less blood went out. So an increase ESV means a decrease in stroke volume, and a decrease in ESV means an increased stroke volume. So you will notice that this always is direct relation, and this is always indirect or inverse. Let's say inverse relationship, okay? Sorry I didn't make this a little bit neater. Alright, now we're going to need another piece of paper in a moment. So here you can see if EDV, ESV are normal, and if I increase the EDV or increase the ESV mathematically, an increase in EDV increases a normal stroke volume from 80 to 110 mils. But an increase in ESV here decreased a normal ESV from a normal stroke volume from 80 to 50. Okay? These relationships are very important to know and understand. Okay. Now you can see here, this is the changes in the ventricles, volume of blood in the ventricles during a normal cardiac cycle. And during normal cardiac cycle, what you are seeing is the EDV is the amount of blood the ventricle fills up with during your ventricular diastole, and after ventricular systole, the blood that's left is in systolic volume, and the blood between those is the stroke volume. Now, ejection fraction. What is ejection fraction? Percentage of EDV represented by stroke volume. So, it is nothing more than, so ejection fraction is percentage of stroke volume represented by EDV, stroke volume, over EDV, to multiply by 100. Now, and I'm going to get my calculator out so I don't look like an idiot when I do that. Because if I'm teaching and trying to do math at the same time, it's not going to work for me. So let's say we had stroke volume, a normal stroke volume of 80, 150 times 100. So 80 divided by 150 times 100 would be about, so that'd be about 53.3%. Okay? So, all you're doing with ejection fraction is stroke volume over EDV times 100. Remember, please excuse my dear Aunt Sally, we're going to do division first in the order of operations. So, you would do this first, then take that value, multiply by 100. Okay? So, if we were to practice some of these here in a minute, we are. I wish I put some ejection fractions there as well, but I didn't. but be prepared to do an ejection fraction. Okay, so let's do some practice calculations. Here we have wanting to find a cardiac output. This cardiac output, I have heart rate is 77 beats per minute, EDV is 130, and ESV is 50. So we need to find that heart rate times stroke volume. Now, cardiac output, we have the heart rate is 77. Stroke volume, we don't know, but we have EDV and ESV to find that. EDV is 130. ESV is 50. Now, what do we do here? Stroke volume equals 130 minus 50, 80. And all you got to do now is take that 80 here, plug it into that, 77 times 80. 77 times 80, so now cardiac output 6,160 milliliters per minute. Okay, we've done that. Let's say we had so here's another one we did. EDV is 120, ESV is 50. So all we're doing is, remember, stroke volume is EDV minus ESV. Here we have 120 minus 50. That's all we need to do is 120 minus 50. 120 minus 50 is 70. Okay. Heart rate here is 100 beats per minute. EDV is 130. ESV is 50. So we know we need to get stroke volume first. We know that stroke volume is EDV minus ESV. And EDV here is 130 minus 50. So again, this is your normal stroke volume of 80. 80 here, what we have is, so stroke volume is 80. So now we have to figure out what is, cardiac output is heart rate times stroke volume. We know that the heart rate is 100 times heart rate is 80. And if we do that, of course, 100. Why did I use that to do that? I don't know why. You can tell I get a little brain dead. I just had a phone call that was kind of stressful. So there's always something. I've been 3 interruptions so far with phone calls and other important things. So it's what I get for being in my office. So we solved those. And we solved them together. Now what I'm going to do is let you guys practice this one for sample. And see if you could do those kind of more on your own. Like I would in a classroom. But if you can practice these, you could have your equations. Now, I think right now the chapter review does not have this in there. Correct me if I'm wrong. Now, if it does, if it doesn't have it, then your test won't have it. Okay. If your test ever does have something that I don't have in a chapter review, what I do is I kind of say, well, my thing on that will be, I will give you guys that as like extra. I basically give you an extra credit. I would have taught it, and if you can do it, but I won't count off for it. If I ever put something that's not in a chapter review on a test, okay. So I'm just trying to remember offhand. I don't have the test in front of me. Alright, now the last bit here, I'm going to have to go ahead and upload this because I got to eat something, and I just had a couple phone calls, and I got to take care of something important with that. So guys, I will need to do a third one. I didn't mean to, but it does work out well because we're going into another important section. So thank you guys. Let me go ahead and upload. Hello everyone, welcome back. So sorry I had to end this lecture a little early last time. Gotten some phone calls, some things I had to deal with. So what we ended off with was the basic cardiac physiology, ejection fractions, cardiodynamics, cardiac output. And we were saying these are some things you're going to have to memorize to be able to do, and here's some examples of some calculations, and then had some things there for you to practice. Now, what we want to start off here is looking at how we affect stroke volume. Now, this is a very important thing that we're going to be looking at, is the factors that regulate stroke volume. How it does do this, this will be huge in working with patients. So we want to start you off first with looking at, we can affect two things to affect the stroke volume. Remember, you affect the EDV or the ESV. EDV in diastolic volume or the ESV in systolic volume. Changing those affects the stroke volume in different ways. Remember, EDV, if you increase the EDV, you increase the stroke volume. EDV, if you decrease it, you decrease the stroke volume. ESV, if you increase ESV, you decrease the stroke volume. If you decrease ESV, you increase the stroke volume. So EDV and SV, same directions. ESV and SV, opposite directions. Okay? So with that, what we're going to see is there is a thing called filling time, and that's the duration of ventricular diastole. Let me kind of give you guys a way of thinking about this. If you had a bucket and a spigot that you turned on the water spigot to fill up your bucket with water, but you only stick the bucket under there for a few seconds. Well, though there is a certain amount of water coming out of that spigot, a few seconds is enough to fill the bucket. Hold the bucket under for a minute, you get a lot more. Hold it under there for 2 minutes, even more. Hold it under there for 5 minutes, you might overflow the bucket. So it depends on how long we allow the ventricles to fill up with blood determines how much blood will be there. So we're looking at factors that affect EDV. If you allow more time for the ventricle to fill with blood, increase filling time, you will now have more opportunity to have a higher EDV. It is like holding the bucket under the spigot longer so that you get more water in your bucket. So that if you increase the EDV, you increase the stroke volume with that. Okay? EDV and stroke volume go in the same directions. Now, if you give it less time, if I don't hold the bucket under the spigot longer and pull it away after a few seconds, there's not much water going to go into your bucket. So if I decrease the filling time, EDV goes down. And if EDV goes down, stroke volume goes down. So the goal here is if we understand EDV and stroke volume relationship here, if we understand this, then this makes sense. And this is called filling time. Now there's another big one. This is venous return. That the rate of blood flow during a ventricular diastole. Now remember, if you're a ventricular diastole, blood is coming to the atria. It's enough to open up the AV valves and start. So that's the venous return. Venous return is how much blood comes into your atria that's going to end up into the ventricle. Okay? So venous return, that is coming back to the heart. So that means, and let me do something here, it's bugging me to no end that I just didn't do this, is, because that's bugging me, is there's a thing called the Frank-Starling Principle. A guy named Frank and a guy named Starling come up with this, two physiologists, and it boils down to more blood in, more blood out. And what that says is if I increase the venous return, stroke volume will go up. More blood in, more blood out. You will see Frank-Starling Principle on this exam. It is a very big, important thing that you know and understand. You will see this in healthcare fields, in nursing school, all day early. Okay, so we want to help you guys understand. If more blood comes into more water comes into a pump, the pump has to pump more water out. More blood comes into the heart, heart has to pump more blood out. More blood in, more blood out. Okay, Frank-Starling Principle. Now to affect ESV. These three things affect ESV. What is it? Preload, contractility, and afterload. What's preload? Now, increased venous return, remember, more blood in, has the effect that it makes the atrial wall stretch outwards. So that's called preload, is the stretching of the atria caused by increased venous return. So venous return, as part of Frank-Starling Principle, causes the preload. And that is proportional to EDV. If we increase the preload, increased preload and EDV, stroke volume goes up, but ESV goes down. If you decrease the preload, you decrease EDV, and you decrease the stroke volume, but ESV goes up. Okay? What this does is it actually affects if the heart is stretching outwards. Now, to help you with this, let me pause for a second. Now, I wanted to do this just to show you, so with the muscle cells, so this is my notes from A&P1. Here we have a sarcomere that's relaxed. Here we have one that's contracting. Now, if, for example, we took this sarcomere and stretched it, when the atria stretch with blood filling, it's going to pull the thin filaments further from the thick, so that when it tries to contract, it can't contract as much, and it's going to make that contraction less. And that's why, and if you can imagine that you're taking this, but then pulling it apart so it can't effectively stretch, can't effectively contract, that's what preload does. It affects the ability of muscle cells to produce a tension, okay, because they're stretching. Contractility is the other thing. This is how hard the muscle cells contract. It's called inotropy. You guys will give drugs called anti-inotropics. And these are drugs that affect contractility of the heart, like calcium channel blockers. Now what happens is, this is how much force the ventricles can actually exert. So remember we talked about during ventricular systole, that the ventricle has to start producing tension, but cannot eject the blood during isovolumetric contraction. Then it produces enough tension to shoot blood out. So this is affected by hormones, like for example thyroid hormones, epinephrine, norepinephrine. It's affected by the autonomic nervous systems, epinephrine, norepinephrine, and acetylcholine. It's also a physical activity. Now, for example, if you were extremely physically fit, like myself, I'm getting a little bit slimmer, been eating a lot healthier, so I've actually have lost a little bit of weight again. Hopefully get more physically active again. But if you're very heavily active, your heart muscle becomes very efficient at dealing with increased preload. We call this conditioning cardiac hypertrophy. It becomes more elastic, so that means when it stretches, the preload doesn't reduce the ability to create a force of contraction. But if you're not very healthy and not very active, your ventricles get thicker. The left ventricle gets even more thick, and it starts to produce a great amount of tension, which raises the blood pressure, which then makes the ventricle get thicker because it has to work harder to pump blood. And this can become, this will kill you. This is what happens when you have uncontrolled blood pressure, is your physical activity is not good enough, your contractility keeps going up, trying to accommodate for that, and your ventricle gets thicker and thicker and thicker till you die. And it becomes a thing called cardiomegaly. Now, what happens here is if our increased contractility goes up, if the heart squeezes harder, then we've reduced the ESV, because if I squeeze harder, there's less leftover. If I don't squeeze as hard, there's more leftovers. So a decreased contractility increases the ESV. Heart doesn't work as hard. Like with the calcium channel blocker, decreases contractility. It's an anti-inotropic. Now, afterload, what this is how much tension the ventricles produce to open up your aortic semilunar or the pulmonary semilunar. Now, remember that when I was doing my isovolumetric contraction, I didn't produce enough pressure to cause a cardiac ejection. And that's because I hadn't undergone afterload. Now, let me help you understand afterload. So you got to imagine an aorta with blood coming down, and it's pushing down on your aortic semilunar. And the aortic semilunar has got to open up against that weight of blood. And that weight of blood is around 80 millimeters of mercury of pressure, somewhere around 80 millimeters of mercury, pressure pushing down on it. So once you get to that, it can open. That's afterload. Now that could mean that you have too much blood, so one of the things that increases afterload is a very high diastolic blood pressure. Blood pressure goes up. malformed semilunar valve, something like that. Now, I've got a way to help you understand that, and that's my old Dennis the Menace slingshot here, okay? And really need to find something to shoot with that other than my fetus model here that I have. I don't need to flip any fetuses with that. Let me pause real quick. I forgot to grab something here to shoot with that. Okay, give me 1 second. All right, let's grab a highlighter. Okay, so what does this have to do with factors affecting stroke volume? Well, this thing here, this little flipper here, this little my little slingshot here, this represents to help us understand factors that affect the end systolic volume. Preload, the amount of stretching, that's me pulling back the flipper. Contractility or inotropy, that's the elasticity, stretchiness of the band here. Afterload is how much force we got to use to knock over an object. So if I put my little marker in here, a pink highlighter into this, and I want to launch it and knock something over with it, well, if I just, the preload, if I pull it back very little, it's not going to launch it very much. If I now go in and pull it back quite a lot more and increase that preload, easier said than done, isn't it? It's what I get for trying to do props in the middle of a class like this. And I pull it back quite a lot, it will fling it with a lot more force. And that is increasing the preload, pulling that back a lot more, okay? Now, if I were to replace this band here with one of these rubber bands that are in my desk, I'm just pulling out all my desk stuff today, and you can see that I was not as prepared as I wanted to be. Somewhere, I have rubber bands in here, and I don't know where I put them. My office is a little bit of a mess right now with all the exams going on. But if I were to replace this with an office rubber band, it wouldn't produce very much force. Or maybe a scrunchie from one of you guys' hair. It's not going to produce very much force at all. Or I could probably even put an even more stretchy, more powerful rubber band in here and really throw it hard, okay? Now, afterload is the amount of force you have to produce to actually knock something over. So give me 1 second. Sorry about that. I actually, when I was moving things around, I hit the button on I ended up hitting my mouse, and it made me upload the video too early. So what I was getting ready to show and demonstrate here, let's say that my little bear here, and I'll make sure you can actually see me real quick, that the little Northeast 8 bear here, and my little flipper here, my little gravel flipper, that if I were to produce enough force, I knew I'd miss him. That's what I get for trying. And I can hit him and knock him over. That's the problem. So trying something like this, props and things. So if I could produce enough force to actually knock him over, that's afterload, okay? So if this was a blood cell, and I'm ejecting that blood cell, and this was my AV valve, and it needs to hit it, if it can produce enough force to knock him over, then that is an afterload that's effective. Now, if the afterload becomes too much, we can't knock it over with this. We would need something more powerful. And that's what we got going on here, guys, is your preload, contractility, and afterload. And this guy can help us understand it. Now, the atrial reflex. We said that this was when the atria starts to stretch. What's going to happen is it stretches. It's called the Baybridge Reflex. It is adjusting our heart rate to that venous return. More blood in, more blood out. There are stretch receptors who trigger an increased heart rate using sympathetic nervous system. It is called the atrial reflex or the Baybridge reflex. Now, sympathetic stimulation using norepinephrine from your postganglionic cardiac fibers, that's your cardiac plexus. It releases norepinephrine. And both epinephrine and norepinephrine can do this as well, especially through suprarenal medulla or adrenal medulla. This will cause the heart muscle cells to contract with a greater force. Because what's going to happen is through CAMP, you're going to bring in more calcium. Okay? Using CAMP that we talk about in endocrine, you're going to bring in more calcium, which is going to cause a greater force. Because calcium, remember, causes an increase in contraction. Calcium is needed, if you guys understand that from AP1, is that calcium is what's going to go into the muscle cells, cause the actin-myosin interactions to be able to occur. Calcium removes troponin tropomyosin complexes, inhibitory action on actin-myosin interaction. Now, parasympathetic activity decreases stroke volume, and it increases ESV. Acetylcholine reduces the force of the muscle's contractions, reducing that stroke volume. It's using the muscarinic receptors to reduce that, using your vagus. Vagal stimulation reduces contractility. Sympathetic increases the contractility. So sympathetic, increase stroke volume, decrease ESV. Parasympathetic, reduce stroke volume, increase ESV. Okay? Now, the hormones. There are a lot of hormones out there. For example, we have many hormones like thyroid hormones, things like that. A lot of your drugs mimic the hormones. They might stimulate or block a beta receptor, for example, or affect calcium ions. Calcium channel blockers, especially those that affect the L-type. We call them L-type channel blockers. They'll reduce the contractility. Now, afterload. Afterload is any factor that restricts arterial blood flow. Now, one of the things is, if the aorta was to be constricted or open, if you constrict it, it's harder to get blood into a small tube. If it's open, it's easier to get blood through the small tube. Okay? So vasodilation, when blood vessels are open, that reduces your afterload. Reduces ESV and stroke volume goes up. But if you vasoconstrict, it's going to be harder to get blood. Think about a very skinny straw, trying to drink from a very skinny straw versus a larger straw. Very easy. So a very skinny straw is going to be hard to move blood through that, a blood vessel that's being constricted. And it's going to increase the afterload, which means your ESV, is increased. It's going to increase the ESV. And it's my type over there. Because if you make it harder to get out, more blood will be left over. And that is my fault for not catching that. That's what I get. I type things and I'll be in the middle and somebody will stop me. So afterload, if afterload ever increases, stroke volume decreases. So if you make it harder for blood to leave the ventricle, there is going to be less blood leaving the ventricle. If you make it easier for blood to leave the ventricle, afterload decreases, stroke volume goes up. Make it easier to leave the ventricle, more blood leaves the ventricle. Okay? And you can see all that here. And what I would urge you to be able to do, honestly, is to be able to draw this, map this out. This makes a great thing for you to do, is really sit down and map this out yourself, and you can see all that there. You can see how EDV is affected by preload. ESV is affected by preload. You can see how venous return affects the preload. Filling time affects the preload, which filling time also affects the ESV. We know that filling time affects, if you have, and it affects the EDV because it affects the preload, and if filling time is increased, there's more blood in. Stimulation makes contractility go up. Vasodilation, vasoconstriction affects all this, right? Afterload is reduced by being able to, if you ever get afterload down, then the ESV goes down. You have less left over, okay? If you ever have more leftovers, this will make a lower stroke volume, okay? So this is something well worth knowing and be able to map out, because this is important that you understand this in cardiac patients. Now there are three factors that affect the heart rate: autonomic nervous system, hormones, and venous return. Now I'm going to talk more about this, and we said we would. Now the autonomic nervous system, ANS, uses the cardiac plexus. The cardiac plexus has both sympathetic and parasympathetic. You're going to have sympathetic and parasympathetic. Now, the thing I wish I did here is what I get from when I type my notes, I'm always in the middle of, like, if I don't do this, and I'm sorry that I did it this way, but if I don't, this won't get done. I won't notice. I never notice it when I'm editing. I only notice when I'm typing or when I'm teaching. Now, the autonomic nervous system, we're going to see that the heart muscles, cardiac plexus, contains a mixture of sympathetic and parasympathetic nervous system. And they come into the SA node and the AV node. Now, sympathetic is more numerous and greater. Why? Well, more neurons, but also there is the suprarenal medulla. Now, the autonomic nervous system controls the heart rate using the medulla oblongata, called a cardio-acceleratory center of the medulla oblongata, gets the heart rate up. Cardio-inhibitory center of the medulla oblongata gets the heart rate down. Okay? So think about the that is, it's the gas and the brake. The gas is the cardio-acceleratory center. The brake is the cardio-inhibitory center. And you can sit here and gas brake to keep the heart rate in check. Hormones, epinephrine, norepinephrine, and thyroid hormones all increase the heart rate. So thyroid hormones will make a heart rate go up. This is why patients who have hyperthyroidism have heart rates that go up, very high blood pressure, eyes are bugging out, very skinny. Venous return. More blood in, more blood out. Whose principle says that? Frank-Starling Principle. Make sure you know that. Tattoo that on your wrist, okay? Now that means there's more blood stretching the atrial walls. That means your heart rate goes up to try to get that blood cleared out, okay? So anytime you ever increase the stretch of the heart walls, that causes your heart rate to go up. This is why when you work out and you move your body, you start to increase the venous return, which starts to increase the heart rate, okay? And you can actually see your cardio-inhibitory and acceleratory centers in the medulla oblongata. Now, this is cardiac output, all of them. Like I said, if you can take this and map it out, you will know and understand this. And I'm going to urge you to make boxes that are blank and fill it in and be able to look what it does. And if you can do this, you really understand it. This is a great thing to do there. This is hugely important. I'm going to ask you what happens if I increase preload. Or if I were to increase contractility, what's going to affect? I'm going to ask you Frank-Starling Principle. Okay? These diseases and conditions are not on the test. I'm not even going to talk about them here. They're there if you want that. These are some basic things. I do have some heart defects in the fetus. These things, like tetralogy of Fallot, has most of these things going on, because it will have a PDA, a patent ductus arteriosus, a ventricular septal defect, right ventricular hypertrophy, and what is called a transposition of great vessels. Can all occur in tetralogy of Fallot. And it's Fallot, not Follett. Fallot. It's French. But you do not have to know that. You're not going to get tested. I just want to get on there. Now, I just wanted to share this. People who have died, we can actually take their heart out and keep this reanimated, so to speak, to keep the heart beating for a transplant. This is increasing the number of hearts available for transplants now. So, guys, that is your favorite thing. Thank you so much for watching. You'll be looking for my arteries and then my veins lab. And then Chapter 21 will be coming out as well. So be watching that. Guys, thank you so much for watching. Sorry that I had the accident when I was trying to show you. I always like to use this as my analogy to help students understand the stuff going on with the cardiac. So without that, thank you guys for watching. Sorry about that. I actually, when I was moving things around, I hit the button on I ended up hitting my mouse, and it made me upload the video too early. So what I was getting ready to show and demonstrate here, let's say that my little bear here, and I'll make sure you can actually see me real quick, the little Northeast 8 bear here, and my little flipper here, my little gravel flipper, that if I were to produce enough force, I knew I'd miss him. That's what I get for trying. and I can hit him and knock him over. That's the problem. So trying something like this, props and things. So if I could produce enough force to actually knock him over, that's afterload. Okay. So if this was a blood cell and I'm ejecting that blood cell, and this was my AV valve, and it needs to hit it, if it can produce enough force to knock him over, then that is an afterload that's effective. Now, if the afterload becomes too much, we can't knock it over with this. We would need something more powerful. And that's what we got going on here, guys, is your preload, contractility, and afterload. And this guy can help us understand it. Now, the atrial reflex. We said that this was when the atria starts to stretch. What's going to happen is it stretches. It's called the Baybridge Reflex. It is adjusting our heart rate to that venous return. More blood in, more blood out. There are stretch receptors who trigger an increased heart rate using sympathetic nervous system. It is called the atrial reflex or the Baybridge reflex. Now, sympathetic stimulation using norepinephrine from your postganglionic cardiac fibers, that's your cardiac plexus. It releases norepinephrine, and both epinephrine and norepinephrine can do this as well, especially through suprarenal medulla or adrenal medulla. This will cause the heart muscle cells to contract with a greater force, because what's going to happen is through CAMP, you're going to bring in more calcium. Okay? Using CAMP that we talk about in endocrine, you're going to bring in more calcium, which is going to cause a greater force, because calcium, remember, causes an increase in contraction. Calcium is needed, if you guys understand that from AP1, is that calcium is what's going to go into the muscle cells, cause the actin-myosin interactions to be able to occur. Calcium removes troponin tropomyosin complexes, inhibitory action on actin-myosin interaction. Now, parasympathetic activity decreases stroke volume, and it increases ESV. Acetylcholine reduces the force of the muscle's contractions, reducing that stroke volume. It's using the muscarinic receptors to reduce that, using your vagus. Vagal stimulation reduces contractility. Sympathetic increases the contractility. So sympathetic, increase stroke volume, decrease ESV. Parasympathetic, reduce stroke volume, increase ESV. Okay? Now, the hormones. There are a lot of hormones out there. For example, we have many hormones like thyroid hormones, things like that. A lot of your drugs mimic the hormones. They might stimulate or block a beta receptor, for example, or affect calcium ions. Calcium channel blockers, especially those that affect the L-type. We call them L-type channel blockers. They'll reduce the contractility. Now, afterload. Afterload is any factor that restricts arterial blood flow. Now, one of the things is, if the aorta was to be constricted or open, if you constrict it, it's harder to get blood into a small tube. If it's open, it's easier to get blood through the small tube. Okay? So vasodilation, when blood vessels are open, that reduces your afterload. Reduces ESV and stroke volume goes up. But if you vasoconstrict, it's going to be harder to get blood. Think about a very skinny straw, trying to drink from a very skinny straw versus a larger straw. Very easy. So a very skinny straw is going to be hard to move blood through that, a blood vessel that's being constricted. And it's going to increase the afterload, which means your ESV, is increased. It's going to increase the ESV. And it's my type over there. Because if you make it harder to get out, more blood will be left over. And that is my fault for not catching that. That's what I get. I type things and I'll be in the middle and somebody will stop me. So afterload, if afterload ever increases, stroke volume decreases. So if you make it harder for blood to leave the ventricle, there is going to be less blood leaving the ventricle. If you make it easier for blood to leave the ventricle, afterload decreases, stroke volume goes up. Make it easier to leave the ventricle, more blood leaves the ventricle. Okay? And you can see all that here. And what I would urge you to be able to do, honestly, is to be able to draw this, map this out. This makes a great thing for you to do, is really sit down and map this out yourself. And you can see all that there. You can see how EDV is affected by preload. ESV is affected by preload. You can see how venous return affects the preload. Venous filling time affects the preload, which filling time also affects the ESV. We know that filling time affects, if you have, and it affects the EDV because it affects the preload, and if filling time is increased, there's more blood in. Stimulation makes contractility go up. Vasodilation, vasoconstriction affects all this, right? Afterload is reduced by being able to, if you ever get afterload down, then the ESV goes down. You have less left over, okay? If you ever have more leftovers, this will make a lower stroke volume, okay? So this is something well worth knowing and be able to map out, because this is important that you understand this in cardiac patients. Now there are three factors that affect the heart rate: autonomic nervous system, hormones, and venous return. Now I'm going to talk more about this, and we said we would. Now the autonomic nervous system, ANS, uses the cardiac plexus. The cardiac plexus has both sympathetic and parasympathetic. You're going to have sympathetic and parasympathetic. Now, the thing I wish I did here is what I get from when I type my notes. I'm always in the middle of, like, if I don't do this, and I'm sorry that I did it this way, but if I don't, this won't get done. I won't notice. I never notice it when I'm editing. I only notice when I'm typing or when I'm teaching. Now, the autonomic nervous system, we're going to see that the heart muscles, cardiac plexus, contains a mixture of sympathetic and parasympathetic nervous system. And they come into the SA node and the AV node. Now, sympathetic is more numerous and greater. Why? Well, more neurons, but also there is the suprarenal medulla. Now, the autonomic nervous system controls the heart rate using the medulla oblongata, called a cardio-acceleratory center of the medulla oblongata, gets the heart rate up. Cardio-inhibitory center of the medulla oblongata gets the heart rate down. Okay? So think about the that is, it's the gas and the brake. The gas is the cardio-acceleratory center. The brake is the cardio-inhibitory center. And you can sit here and gas brake to keep the heart rate in check. Hormones, epinephrine, norepinephrine, and thyroid hormones all increase the heart rate. So thyroid hormones will make a heart rate go up. This is why patients who have hyperthyroidism have heart rates that go up, very high blood pressure, eyes are bugging out, very skinny. Venous return. More blood in, more blood out. Whose principle says that? Frank-Starling Principle. Make sure you know that. Tattoo that on your wrist, okay? Now that means there's more blood stretching the atrial walls. That means your heart rate goes up to try to get that blood cleared out, okay? So anytime you ever increase the stretch of the heart walls, that causes your heart rate to go up. This is why when you work out and you move your body, you start to increase the venous return, which starts to increase the heart rate, okay? And you can actually see your cardio-inhibitory and acceleratory centers in the medulla oblongata. Now, this is cardiac output, all of them. Like I said, if you can take this and map it out, you will know and understand this. And I'm going to urge you to make boxes that are blank and fill it in and be able to look what it does. And if you can do this, you really understand it. This is a great thing to do there. This is hugely important. I'm going to ask you what happens if I increase preload. Or if I were to increase contractility, what's going to affect? I'm going to ask you Frank-Starling Principle. Okay? These diseases and conditions are not on the test. I'm not even going to talk about them here. They're there if you want that. These are some basic things. I do have some heart defects in the fetus. These things, like tetralogy of Fallot, has most of these things going on, because it will have a PDA, a patent ductus arteriosus, a ventricular septal defect, right ventricular hypertrophy, and what is called a transposition of great vessels. Can all occur in tetralogy of follow. And this follow, not follow it, follow. It's French. But you do not have to know that. You're not going to get tested. I just want to get on there. Now, I just wanted to share this. People who have died, we can actually take their heart out and keep this reanimated, so to speak, to keep the heart beating for a transplant. This is increasing the number of hearts available for transplants now. So, guys, that is your favorite thing. Thank you so much for watching. You'll be looking for my arteries and then my veins lab. And then Chapter 21 will be coming out as well. So be watching that. Guys, thank you so much for watching. Sorry that I had the accident when I was trying to show you. I always like to use this as my analogy to help students understand the stuff going on with the cardiac. So without that, thank you guys for watching.